It's my honor today to introduce Dr. Daniel Hashimoto. He is our UCSF Carroll and Orlo Clark Distinguished Lecturer in Endocrine Surgery. This award is supported by the AES Foundation, and this is very important for you to know because all the donations that you give directly to the foundation help support lectures like this, state-of-the-art lectures that are important to our organization. I've known Dan Hashimoto since he was a resident at Massachusetts General Hospital. His father was a surgeon, and I think he tried to run away from that profession for a little while, but eventually saw the light, was a student at Boston University, and then at the University of Pennsylvania, where he went to college and medical school, and also got a master's degree in translational research. During his time at MGH, he was one of the most impressive people I've ever seen. He really ignited the passion in the whole department for looking at ways to improve quality and safety in patient care. And he had a background in engineering, and he had a background in machine learning, and he started a whole process that he's going to talk to you about today. I looked back at some of my texts, which I often do when I have to introduce residents, and I apparently trusted Dan so much that at some point when he was a third-year resident, I texted him to say, "My dad's in the cath lab, but you go ahead and get started. I'll be up in a couple minutes." So just to show the kind of confidence I had in Dan. Dan, I think, is a very good example of how we need to learn from our younger members and our residents and our fellows. Even though Dan is an assistant professor of surgery, he has done more than many of us could do in a lifetime. He's had papers in the New England Journal of Medicine, in Nature, Biotechnology. He's been in The Atlantic, in CBS News, in PBS NewsHour. And throughout this time, I think he's helped many departments of surgery, unfortunately no longer MGH because he's currently assistant professor at Penn, where he leads the Picasso lab, the Penn's computer-assisted surgery and outcomes lab. But he has shown how we need to stay current in this area, and this is why I invited him to be our distinguished lecturer. Dan, please come up.
Well, thank you very much, Dr. Parangi. Thank you to the program committee and to the AAES for really the distinct privilege of having the name Hashimoto and addressing a lot of endocrine surgeons. So thank you. It is indeed an honor. And certainly, I, as a foregut surgeon, I'm not coming here under the pretense of teaching you anything about endocrine surgery. But hopefully, with everything that's been happening recently around artificial intelligence, computer vision, robotics, I can give you a little bit of perspective, partly with my engineering hat, partly with my surgeon hat, about how all of this really rapid change that's really feels like it's only been the last 4 years that things have kind of exploded, how that really might intersect with our professions as surgeons, our calling as physicians, and then just our lives as human beings, and what does that mean with technology? A couple of disclosures. I am a consultant for Medtronic. I'm not going to talk about any of their technology. I am a co-inventor on a patent that's owned by MGB, which means I have seen zero of any downstream effects of that. I'm going to talk about some commercial products like AI tools that all of you know and have accessed. I don't get anything from them. If you know anybody there who would like to give me something, please let me know. I want to start, though, first with just gratitude to Dr. Clark, who I did not know personally, but I had the opportunity to learn a lot about him in preparing for this. UCSF has a really wonderful video about his career, and Dr. Shen wrote a really amazing piece about his life and how he met Carol, his wife, over a plate of spaghetti when they were in high school. But Dr. Clark really sounds like, with his, of course, he's got impressive credentials, like any forefather of a great surgical society like the AAES. But it sounds like the impact that he had by training over 100 fellows, which that kind of boggles the mind about how you can train so many people in that career, really sort of lends credence to this idea that surgery is bigger than us individually, and the individual relationships we have with our patients, and really extends to how we can influence that next generation who will continue to make ongoing changes and impact in people's lives through the lessons that we learn. And what I'm hoping I can do today is tie in a little bit about what does that sort of passage of knowledge, of information look like when technology can sometimes feel like it's taking some of that role from us, or maybe changing the way in which we relate to information, knowledge, wisdom, experience, and expertise. And before I get to the parts about surgery, I want to show you something from other industries. So this is a video of a little cart. And you can see this little cart is moving, it stops, you see flashing white light. Those are photographs that are being taken. This is the Stanford cart in 1979. This is an autonomous vehicle that is taking pictures to understand where it should navigate to next. How many of you have a Tesla or something like that? I was just talking to people, you know. One question I typically ask when I first show this is, in what year was self-driving first sort of demonstrated as being really feasible on public roads? And oftentimes the response I get is around the time that Tesla came out, right? So like 2010s and whatnot. But really it goes all the way back to 1986. So this is an example of Carnegie Mellon's NavLab van. So you can see it's an enormous van because it needs to hold all the technology. That's the view that it has of the kid on the bicycle crossing. Very, very different. I don't know how much you would trust a car that has that type of vision to navigate through your neighborhood, but it's 1986, right? What was our expectation back then of a self-driving car? Was that even in the public consciousness at that time? And then, interestingly enough, now you see something like this, where you see the human driver might be sitting in the car. This now probably looks a lot more like your screens in your Tesla, if you have one of those, or if you've been in a Waymo, because you can see how it's highlighting other cars in red. It has a very up-to-date display system, displaying all of the metrics that it's checking on its odometers. And this is in 1995. And in 1995, the University of Munich did a test where they drove this car for 620 miles autonomously in Paris. Right? So this was 30 years ago. It was going 81 miles per hour, and on top of that, they could convoy the car. So they could take multiple cars driving autonomously around Paris. And yet here we are in 2026. Most of us are still driving our normal cars. And for those of us who are worried about our radiology friends also drove to work in their cars. And it's not like all these things are being done autonomously just yet, right? But things are getting closer, right? So for any of you who went to the college a couple of years ago, the Waymos are driving around San Francisco, LA, Phoenix. I think they're creeping into Boston and Philly, but they don't trust the human drivers just yet, and so they won't let them loose there yet. But it's fully autonomous, right? In fact, I'll tell you, my youngest sister takes a Waymo to work rather than driving, and she lives in Phoenix. And so we've made big advances, but it has taken this span of time from the 1970s to 2026 to get to the point where we feel like we have reliability in these systems. And when we think about some of the problem spaces that had to be solved in driving to achieve autonomous cars, it's things like detecting shapes and objects, understanding the context of what's happening when you're navigating from point A to point B, thinking about 2D to 3D geometry if you're using a two-dimensional camera, understanding viewing things from different angles, multi-view geometry, tracking motion, etc. All of these things are also problems in surgery. These are all of the things that we're trying to solve today when we think about how we want to better understand the complexity of our jobs as surgeons. And so one of the questions is, can computers really help us to be better surgeons? Surgery has existed for thousands of years. Why is it that a machine should come in and change the way that we do things, right? There was a T-shirt that they used to give out at MGH. It was, when you finished intern year, it said 200 years of tradition unimpeded by progress and innovation. And so that's sort of a thought about how we think we may want to deliver care. But when we think about improving visualization, especially now that so much surgery has started to shift toward minimally invasive surgery, computers are already a part of how we do the operation itself, right? So if you're doing a lap or robotic adrenal, there is a computer interface between you, even in laparoscopy. And it helps us to see what we need to do, but the question is, can it augment what we're seeing to make us better surgeons? Does anybody know which one of those pictures is real and which one is generated by an AI? So the one on the left is actually the one that's generated by an AI, and the one on the right is the real operation. Right? Some of it anatomically a little weird, but these machines are getting quite good at generating images de novo to show some of these things. Probably the giveaway is that there's this random ductal structure there on the left that I'm not quite sure what that is. But otherwise, if you look at the texture of the liver and whatnot, could be believable, right? And I think it's important to understand that we're in evolution right now as surgeons, right? When you think about the history of surgery going back to, in 740 BCE, the Incas were doing trepanation. That's before ether anesthesia, that's before antisepsis. And so that was truly, you want to talk about a patient-doctor relationship. There was nothing between that patient and the physician, maybe like a bottle of pisco, which is Peruvian brandy, as anesthesia, and that's about it, right? Today, we're very much device-enabled surgery. I listened to some of the devices that were being used in the thyroid talk just before, right? Some of them, I don't even know what they are. But we're very much now dependent on devices, our Bovies, our CT scans, our ultrasounds, et cetera, to deliver modern medicine. And as we've realized that all of these devices are also sensors, we have started this evolution now into not just device-enabled surgery, but data-enabled surgery, and understanding how that data helps us to make better decisions as surgeons. And really to help us do that, we've tried to coalesce terminology around this into this concept of surgical data science, right? And even though it says surgery in it, it's meant to be bigger tent than that. Anything procedural falls into that. So our colleagues in IR, gastroenterology, pulmonology, the ER, ICU, et cetera. If you're doing a procedure, you fall into this bucket category of surgical data science. And the data is broad. It's not just about this EHR that tortures us every day with flags, alerts, and documentation, et cetera. It's thinking very broadly about what counts as data. It's not just data about the patient, but it's the data about us, right? What devices do we have on us that may or may not measure, our heart rate variability while we're operating, for example. Or Dr. Carla Pugh at Stanford is now using EEG to better understand cognitive load in surgeons while they're doing surgery. And the ultimate goal is to yield quality improvement. And that can be QI in the traditional sense, right, of improving processes and strategies. But I think in this space, our holy grail is, can we predict and therefore prevent adverse events from happening? And can we use this technology to deliver just-in-time decision support to allow us to prevent these adverse events and optimize the outcomes for our patients? And to do that, we've had quite a few achievements in the field over the last 10 years as we've gotten better at leveraging tools like artificial intelligence to help us better understand what's happening in surgery. We have AI models now that can help us do things like understand safe and unsafe planes of dissection, really hone in on critical tool-tissue interactions, segment out critical parts of anatomy, and then help us understand what part of the operation is happening when, so that we have a better sense of context for these models to improve the types of decision support that they can give us. Greg, can you mouse over this image for me? This is an example of work that was led by Amin Madani, an endocrine surgeon who's on a panel tomorrow in gallbladder surgery. This is our go, no-go zone model. So in green, this is our Google Maps, basically, right? So in green is the safe area of dissection that the surgeon can follow to safely stay away from a common bile duct injury. The red is what the surgeon should avoid to try to avoid injury to the common bile duct. Now, this was doable over 6 years ago, right before ChatGPT, using sort of the traditional neural network, convolutional neural network models. Some of this has been expanded by our other colleagues, like Pietro Mascagni in France. This is AI support for the critical view of safety, not just highlighting those structures, but telling you conceptually, did you achieve the 3 criteria of the critical view of safety, so that you don't necessarily have to call a partner in to help you confirm it on a tough gallbladder. But maybe this AI could be your coach that can help visualize or give you some assurances around what it is that you're seeing. I think more interestingly now is then actually diving into things that we do in the operating room. So pulling from the urology space, this is Andrew Hung's work from Cedars-Sinai. When we do operations, we are engaging in a series of surgical gestures, right? So that's what those little color boxes on the left are, the corresponding gestures that you might do during robotic surgery: spreading tissue, hooking tissue, cutting it, peeling it, etc. What's interesting is that if you were to map all of the gestures that you do over the course of an operation, you might start to see some patterns, not just in what it is that you do, how you do it, and what the impact is on the patient. So in prostatectomy, one of the important sequences is the nerve-sparing part of the prostatectomy, so that patients can recover their erectile function and urinary continence. And so what Dr. Hung did is, on that upper right in panel B, what you see are different sequences for different patients, where patients recovered erectile function at 12 months after the surgery and where patients did not. And he's able to use machine learning tools to predict at the time of surgery whether those patients would recover their quality of life 12 months out after the operation. Some of those things seem obvious. These are the dogmatic things that we cover in surgery. Are you near a nerve? Don't use your bovie because we have electrothermal spread, right? But all that is just teaching. Like, it's teaching from concepts in physics, it's teaching from experience. But what Dr. Hung was able to do is actually show quantitatively that, yes, actually, when you use monopolar electrocautery near the nerve, you actually make a difference, negative difference, in that patient's outcome 1 year later. And this is that clinical data that supports that if you're near a nerve, you should use non-quote-unquote hot gestures to try to preserve nerve function, because those hot gestures are going to put you and the patient into an uncomfortable situation 12 months later. And so this is where these tools are allowing us to look at our operations under a new lens, with more objective, quantitative approaches to understanding how the decisions and the actions that we take in the operating room are impacting the outcomes of our patients, beyond what we sort of internalize over 7, 8, 9 years of residency and fellowship training. The next sort of step beyond that is then to say, well, if we can identify the gestures, can you identify specific procedural elements around, for example, suturing? So this is work being done in my lab on robotic Whipple, where we are able to track the specific position of the instruments. To shout out some of the trainees in the group, Shivan Gupta is one of our engineering students, Rachel Acker, who's here, is one of our surgery residents, and Sharon Lee is one of the MD master's students applying into surgery. But we know that when we are operating, when we are suturing, we suture in a 3-dimensional space. In MIS, we often see in 2 dimensions, but we need to better understand how to change that 2D to 3D so that we can do accurate things like tracking the needle as it passes through tissue. Now, it's one thing to look at it in 2 dimensions, but we know that 2-dimensional tracking doesn't give us real accuracy around, did you put that needle in the optimal place to prevent a leak? So we can pull from other industries. I don't know how many of you in the room have TikTok on your phone, but TikTok actually has a whole research division. And so this is actually borrowing TikTok's algorithm to take 2D to 3D depth, and actually being able to take a 2D image and infer relative depth. What does that allow us to do? It doesn't allow us to really sort of analyze the dance moves of this particular surgeon, but it does allow us to get something like this Monday Night Football type of camera, where if we want to better understand exactly where this needle went into this tissue, you can then rotate this to get different views to better understand what is the individual contribution of decisions that we make during the operating room that may have an impact on something like a postoperative pancreatic fistula. And we do see correlations of some of this with that clinical outcome and with the actual sort of quote-unquote subjective assessments of other peer surgeons who are looking inherently at this type of behavior and trying to understand how this all flows together. But of course, it's not feasible to go back and watch every single one of your trainees or your partner's cases. So can we offload some of that to get quantitative feedback from some of these machines that apply or that can offer that automatically? The very next question I usually get after I show some of this work in robotic surgery is, well, how much longer before it starts doing it on its own, right? So this is work done by Ken Goldberg at UC Berkeley. He's one of the robotics engineers there. So you can see the very similar or familiar form factor of these instruments, except that they have a little sort of beige piece on it that helps it load the needle. This is suturing this piece of tissue pad totally autonomously. Now, this is pretty painfully slow for those of you who've had to watch your trainees sew sometimes on the robot. This is sped up 4x, right? But the context, I think, that I should give, this video is 10 years old. So 10 years ago, we already had autonomous robotic suturing. What has happened in the last 10 years? The prior video shows very discrete instructions to the robot on how to accomplish this task. More recently, it's able to do things like this. You see those little beige holders are gone now. This is Axel Krieger's work from Hopkins. And you can see that if the robot misses, it can try again and adjust its behavior. It can do things like lifting tissue, not just sewing. And the most interesting part of that is that nobody told it to do that. It just watched videos of other surgeons doing it, right? So it's something called imitation learning. I think probably you may have seen this talked about in the news. This was a big paper in Science Robotics that came out last summer. Let me see if I can get this video to play. This is a fully autonomous robot doing the clipping and cutting portion of a porcine robotic cholecystectomy. Now, you'll notice at the top left, you see some text. What's actually happening here is that the robot visually takes in the field, translates that visual field into a set of written instructions. Those written instructions are then fed back to the robot, and then the robot is following those written text instructions generated by an AI. Now, those text instructions can be checked by a human being, but it is basically a closed circuit. AI watches the video, AI generates a set of instructions, gives it back to a robot. Robot then autonomously can go in and execute the plan. Sounds like you don't have to show up for work on Monday, right? It is, of course, incredibly impressive, but there's a reason it's not in our operating rooms yet, and we'll get to that in a minute. Expanding outside the operating room into something that's maybe a little more tangible, I bet most of you either have had access to, have tried, or are currently using ambient scribes, right? This is a study that came out in JAMA Network Open that found that actually, interestingly, there are about 74% lower adjusted odds of burnout after using an AI scribe. Now, a study that came out this month from MGB showed that on average, a clinician across 5 different academic health centers where they trialed ambient scribes saved 16 minutes a day. That's it. 16 minutes a day in documentation from using an ambient scribe. And yet most of the papers coming out show that despite that very small time savings, this phenomenon of the burnout rate coming down and cognitive load coming down is fairly reproducible. I don't quite understand it just yet because every time I use an ambient scribe, I have to correct it a lot. But there's something to be said about the way in which these technologies are coming into our spaces that may be allowing us to use our minds a little bit differently. And it may not be explicit, and so it may be hard to describe quantitatively or to measure objectively as to how it's making a difference. But for some reason, it is impacting our sense of how we feel at the end of the day, even if it doesn't seem to be making that much of a meaningful difference in the amount of time we spend doing it. The thought is that if these things are going to help us make better decisions, that it should probably understand the domain in which it's functioning, right? So we think about things like, well, how do these AIs do on tests, right? This is how we evaluate our medical students now for our residency programs. And what we see is this sort of evolution in performance of these models and how these large language models that you have commercially available can do. GPT-3, so ChatGPT was 60% on USMLE Step 2. GPT-4 was 85%. Today, GPT-5 does 97% on Step 2. You would rank this student to match, right, if you looked at their Step 2 score. This just came out this week from MGB. Clinical vignette performance when evaluating base large language models. That is, any of those large language models that you can pull up on your phone, ChatGPT, Gemini, Grok, what have you. If you only look at the overall accuracy in answering questions from the Merck manual, these models score about 80 to 90% in overall accuracy in answering clinical questions. But we all know that the patients who show up to our clinic are not wearing a multiple choice answer sheet on their chests. And so this prime LLM score is actually a multimodal score that more accurately breaks down the different things that we do as clinicians when we are engaging with our patients. Most of our patients are coming to us seeking answers, and they're not going to come with all, well, maybe some, I guess we're subspecialists, but they're not going to come with all of the testing all done and neatly wrapped up with a bow, right? So what do we have to do? We have to generate a differential diagnosis, we have to order diagnostic testing, we have to come to a final diagnosis, and then we have to decide on management. And then, of course, there are like miscellaneous clinical reasoning things that we may want to do. So 80 to 90% accuracy overall when you're just looking at, does it say the right thing at the end? This is what I find interesting. What I want you to look at here, this is failure rate, not accuracy. FD and DD are the two things to look at there on each of these graphs for each of these large language models. DD is differential diagnosis. Notice these are between 90 to 100% failure rate in accurately generating the differential diagnosis. And actually, let me rephrase that. It's not even generating the differential diagnosis. It was given a multiple choice list and told to select all that apply. And almost none of these models could do that well. If you gave it all of the information, once you had all of the testing and everything, it did a very good job of coming up with a final diagnosis. That's what that FD is. But it had a tough time with DT, ordering the diagnostic testing. So when we think about how we evaluate the performance of these AI models, it's all well and good to see the lay press publishing these big headlines about how doctors are no longer needed because we can hire AI. AI is just as good as a doctor at diagnosing XYZ. But what those things often leave out is this, that these models are not as good at the process. If you had everything too, you would probably get the right answer at the end, but you're actually having to think about how to get you the information that helps you come up with that final diagnosis. So that is to say, you do have to show up to work on Monday. Why is it that we're having these problems with these models, even though they can do really impressive things like drive you in a car with no driver, that they can do things like clip and cut the gallbladder? This is an image generated by two of the very large commercial large language models. And I asked it to depict 24 endocrine surgeons at a conference. Can anybody tell me or give me some feedback about what you think, how well you think these models did? How would you rate the performance of these large language, or vision language models, I should say, in generating these images? Does it look pretty realistic? Do those look like endocrine surgeons to you? Yeah. Does it capture adequately maybe the diversity of endocrine surgeons that may show up? They're smiling, right? I specifically asked it for 24. If you count the number of surgeons in each of these images, there's 25 on the left, and there's 22 on the right. How many of you had a software do your taxes last week? right? We trust machines to do things like math, but these machines can't, even though when you dig into the chain of thought reasoning of these models, right, this is what was going on under the hood. The central concept is to have exactly 24 surgeons in the image. The current goal is 24 distinct surgeons, and it still got it wrong. These models can't count, right? They can't do basic arithmetic very well, and that is a function of how these models are programmed, right? These models are programmed very differently than your tax software that is designed to count and multiply and follow rules. So there are inherent design limitations of the current generation of AI models that, as impressive as it can be in generating realistic-looking photographs, can't do basic counting that my 5-year-old can do, right? I think the other thing I should point out, we inherently sort of trusted the number part, right? At least I didn't hear anybody point out the counting piece. I think that's an important lesson when we think about interacting with these models. We have had a lifetime of learning how to evaluate knowledge from other human beings. If I were to ask Dr. Parangi a question about endocrine surgery, I would just blindly trust whatever it is that she told me. If I were to ask her a question about Formula One car, do you like Formula One? I don't know. Yeah, I probably wouldn't. I'd be like, I should probably double check that work, right? I have a sense of where the boundaries of her expertise are. That is not the case with these models. You don't know what it's good at and what it's not good at. And some of the things that you think it's good at, like counting, you take for granted and it's actually not good at. That's actually where the danger of these models comes in, is that we have not yet learned how to change the psychology of how we as humans interact with knowledge coming from these types of systems. And I think it's a very valuable lesson in thinking about what do we want to offload to these types of technologies and what do we want to keep under human control. I think some other concerns are thinking about data. Is it that every company needs to gobble up all of our data centrally? Or do we have ways to preserve privacy? This is work done by my postdoc, Weiqu Liao. Actually, turns out that if you put all the data in one place, AI models do worse because of the inherent noise coming from differences in data collection, data sources, technique, patient population, et cetera. They all start to cancel each other out a little bit. But if you do what's called federated learning, where you have a base model, and then you have individual lessons coming from individual places that exchange that knowledge, you can actually preserve the pattern of learning and the pattern of practice at your local institution while pulling the broader lessons from the whole. Your phones do some of this, right? So both Android phones and iPhones do some bit of federated learning. There are some things that happen on your phone locally where that data won't leave, but it can get some of the weights from the larger models at Google and Apple to make it better at predicting your own behaviors and understanding your voice, for example. Going back to this question of assessing the performance of models. All of us in medical school were taught sensitivity, specificity, AUROC, and these are the things that we look for in papers, right? When we're reading about, look, this new AI model is going to help you diagnose a thyroid nodule better automatically, right? But we know that not all numbers are made the same. So we're in Kentucky, so if I tell you that a 40-year-old male can play about 35 minutes of basketball, the person that shows up on the court may look like this, or may look like this. Performance is not the same. I can guarantee you that, right? So age and the amount of time you can spend on the court, I don't think I can actually do 35 minutes anymore. But that is not a very good metric of performance. And yet, for some reason, we want to cling to the metrics that really seem familiar to us. This is from work that we had the opportunity to collaborate on. Is a big multi-institutional study with 64 institutions across the world, actually looking at metrics of AI performance. So this is an example from radiology, but I think it gives a good sense. So if you look at these brain images, On the left, you see in reference, that's what the radiologist said was the tumor, and that prediction on the right is what the AI model said was the tumor. Looks pretty good, right? So if you take voxel level sensitivity, this model is about 94% sensitive in detecting each of the individual little voxels that identify this brain lesion. This is what the company's going to come sell you, right? If you look on the right, there's a little lesion there in the cerebellum in the reference image that's missed by the AI. Is it more important that you detect every single voxel in a lesion, or do you want to detect how many lesions are in that scan? So while your voxel level sensitivity is 94, your instance level sensitivity is 50%. Doesn't sound so good anymore, right? And yet as clinicians, that's what we care about. As an engineer, I understand why you're trying to optimize for voxel level performance. That's what looks good. That's what gets you published, right? But really what matters when you're translating into clinic is what matters to the clinician. It's how many lesions, because that's going to change the way we treat that patient. If you're ever evaluating a paper or you want to know, particularly one that involves imaging, this is actually a walkthrough tool that will take you through that. You can scan that QR code. It will ask you a series of questions, and you can actually put in, like, here's what these authors said they were doing, or here's what I want to do in my study. What are the right metrics that I should pick to be able to do my evaluation, to understand if I'm being actually told what this performance is meaningfully in a clinical setting. So what do we need to move forward, right? We have all these sort of like aspirational type things about autonomous robotic surgery and AI guidance to better understand what's safe and what's unsafe. But then I went through and just shattered all that with like, look at how dumb these AI models are, right? To get there, we really have to think about combining with engineers to understand how we can help solve some of these problems. Part of this is like the data is not that readily available, right? We have them in each of our institutional silos, but the engineers can't really get to them. At SAGES, we partnered with MICAI, which is the Medical Image Computing and Computer Assisted Intervention Society. That's the main engineering home for engineers who work on computer vision and AI. And we put together a consortium of surgeons across 24 different countries to get 1,000 videos of lap and robotic chole. And we had teams of clinicians go through and label those videos, de-identify them, and then we release them publicly. So you can actually go online and download all 1,000 of these videos if you want, right, to train your AI model. Because at the end of the day, what we want is we want to be able to solve these problems in a manner that is democratizable, right? So if you open source some of these problems, it makes it easier for people to solve this. Because it shouldn't just be somebody sitting at Google, Apple, I mean, I'm going to randomly throw out these companies' names, right, that get to decide what healthcare problems get solved and for whom, right? So that's where we as surgeons have a role to play in thinking about how we want to collect our data, obviously partnering with our patients, and think about how societies can play a role in creating some of these databases to unlock the clinical questions that we have that could potentially be influenced by these types of technologies. The next step in that is actually this year's challenge, the OR Arena Challenge, that was sponsored by the Welcome Leap Save project. And this is really trying to go after this counting problem and what we call long-term context. So if you know any engineers or you're interested clinically in this problem, this is the idea that over the course of an operation, you do things like put in needles into the body, right? Put in sponges, and you keep track, but how many times has the count been off? How many times have you had to get an x-ray because the needle count is off, right? So this is, can we create data sets that allow engineers to solve for this problem of a sponge went in at minute 5, but it didn't come out until minute 98. Because right now, large language models can't see further than 15 minutes. And they don't really have great example cases where that matters, except in surgery, right? And so these are the ways in which surgery can also have an influence on the broader development of AI technologies. I think one big question when we design AI models or we think about how we influence AI models is how much do we expect AI to think like us? So this is an image of that go, no-go zone from the gallbladder that we gave to 2 different models, commercially available models. And we asked it to explain why the area in green is safe. And if we were to sort of summarize all of the answers, it highlighted things like saying, well, the cystic duct is here, this is the gallbladder, therefore it must be safe, right? When you ask a group of surgeons, they sort of hone in on different parts, right? Of course, yes, this is the gallbladder, but they think about the hepatocystic triangle, right? That's not mentioned by these large language models. We think conceptually about what's safe and unsafe in a different manner than some of these models are. And the question is, if an AI is going to explain its decisions to us, how much does it matter that its explanations are plausible, that they're faithful to how we conceptualize the problem, and that they're aligned with how we would explain it? I would argue that probably in the beginning it should be aligned. Why? Because we have to establish trust. This is somebody new. This is your resident scrubbing in with you for the first time, and you don't know what the boundaries of their limits are, right? But as you work more with these models, you start to maybe bestow a little bit more trust, a little bit more autonomy. And at some point, we have to ask ourselves, why are we going to constrain these AI models to think like us? Why give it the same limitations that we have when it might approach the problem differently? And even if we don't understand it, if we can show that it gets us better outcomes and is safer, better, more efficacious for our patients, does it matter that we biologically cannot understand how it's coming to these conclusions? I can't answer that question definitively, but that's really more food for thought about what we expect from our AI models and our technologies. So at the end of the day, as we think about incorporating these tools, that there's like 50 new ones every single day, we have to ask ourselves, when do we want to use these tools? Do we want to use it to do preoperative decision making? Do we want to use it for intraoperative guidance? And does it come down to what types of tasks we want to give it, right? What are easy things that we can give away that may not have a significant impact on patients? If it understands context from a video, maybe it can draft op notes. I bet it probably understands the coding rules better than we do, and so it might know how to optimize billing more than we do. It's just from watching our videos, right? And at what point should it augment what we see or how we see things, right? It can see things in different spectrum of light, right? So we have hyperspectral imaging cameras in some scenarios that we can use that can see beyond what we can see. You guys know that the parathyroid autofluoresces, right? So you can use fluorescence in different ways. These are ways in which we are augmenting our abilities as human beings and not necessarily abdicating our responsibilities or our knowledge and expertise to accomplish our goals. And then there are some things that maybe we should hold on to because the complexity of the decision needs to be personalized and specialized to one individual who is in front of us at that moment. I tell my patients when I'm consenting them, the risk of this is 0.03%, but if it happens to you, it's 100%, right? And so when we are making a consequential decision with our patients, is it our responsibility, is it our obligation or our duty to think about that from the perspective of a human being that thinks about this individual in front of us and doesn't just level things out statistically to make that decision? And what happens when it makes a mistake? So we've all seen the Swiss cheese model, but now we have to update the Swiss cheese model because the Swiss cheese model now goes beyond what we typically think about in terms of, well, there's a handoff in communication and blah, 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 blah. This now goes back to things way outside of our control, which is, well, what kind of data was collected to build this model? Who calibrated that model? And if that UI or that user interface doesn't allow me to understand whether this AI model applies to my patient, and I can't interpret it, and I was never taught how to use it and what its limits are, am I going to get to the place where I'm going to look at something that an AI tells me to do and I'll do it, and then I cut something that I shouldn't, like the common bile duct, right? That doesn't happen in isolation. There are a series of decisions that get made well before that happens, where we can intervene, and we have to ask ourselves, how much do we want to intervene along the way, and what are we comfortable with? We don't have, by the way, ground rules on any of this yet, right? Every institution is grappling with governance questions around this right now, mostly at a one-to-one level. And so we have to be there to advocate for ourselves as surgeons. Otherwise, people who are not surgeons and may not fully understand this context may make some governance and framework decisions that are ultimately not helpful and potentially unsafe in the way that we deliver care. And then finally, de-skilling, right? I think this comes up quite a bit. I think Dr. Hoden asked me about this 10 years ago when I was first talking about some of this stuff. He was like, what happens when we take the AI away? Some of these quotes, right? Those who think they can leave AI instructions for an art, right? It must be quite naive and truly ignorant. Are we going to really abdicate everything to an AI, right? And AI, guess who gets to use AI? Everybody, especially today, right? Those who know how to use it and those who don't, right? Except these quotes are actually not about AI, they're about writing. And Socrates said this when writing was first coming around. He thought writing was going to lead to really a breakdown in the ability for humans to communicate with one another. Because we would lose the ability to have the spoken word and to have conversation and Socratic discussion. And yet here we are thousands of years later writing things down. Actually, now computers are writing things for us, right? But I think this just highlights that this fear that we're going to lose something because something new comes along has long been embedded in us as human beings. And as much as sometimes we like to think it's ending, the world has not quite ended just yet, right? As we've adopted these new innovations and technologies. But it is up to us to think about how we want to implement those technologies in a way that is conducive to progress, however you want to define that progress. And that is something that is well within your control as surgeons, clinicians, leaders in surgery to really make that determination. It is not going to be that NVIDIA gets to decide how we're going to do surgery 20 years from now, because you have a say in how this gets implemented, even if you may not be building the machine yourself. So ultimately, when I think about what at least the near future of AI-enabled surgery is going to be, is not this doomsday automation scenario, right? But it's much more of this augmentation piece. How can we sort of put on this augmenting technology to expand our abilities as clinicians to better care for our patients, as opposed to how do we replace ourselves and have this doomsday scenario? Because this is much more realistic, and rather than worrying about, this robot's going to come take part of my job and we shouldn't let it, and da-da-da-da, we probably need to be spending much more of our mental energy and effort on the appropriate implementation of what's coming now to make ourselves better and put in some of those delineating lines. None of this can happen without team science, so I do want to give credit to some of my collaborators across engineering, implementation science, and the School of Education, as well as, of course, the many students and trainees who are involved in building some of these technologies and honestly keeping me up to date on what's happening because it's constantly changing. But what I hope to leave you with is really that challenge to say that all of you are certainly empowered to think about how these technologies are going to get implemented. Even though sometimes it feels like there's some executive that made a decision that this thing's now in your clinic and what are you going to do? You have some say in the process. You're the ones taking care of patients. Your patients are also going to have a big say in how these things get implemented. And so, it is through societies like the AAES that I think you can advocate for the responsible implementation of these technologies and honestly the development. So thank you very much. And I really, really appreciate the honor to speak to you all today.
I was just going to actually give 5 minutes for questions. So if anyone has any questions for Dan.
Yeah. Does it work or no? Can you hear me now?
Yes.
Hi there. Alex Flores, Texas Tech El Paso. Fantastic presentation. I haven't seen something like this in a very long time. Thank you. So many questions. The first one, which I think is the base, is where do you see medical education going? And the reason for that is I feel that there is a huge divide between three principles: medicine, math, and computer coding. And though I do agree that we have to partner, the problem is that I don't speak math and I don't write code. I do, but let's say the general physician doesn't.
Yeah.
And the engineer doesn't understand medicine. And if I can't speak your language and you don't know what's important for me, I don't know that that partnership will work. So the question for me is it time that calculus, probability theory, linear algebra, and advanced coding should be in the curriculum pre-medicine, medicine, and residency for everybody?
That's an interesting question. I think the math piece is always important, right? I always sometimes will joke with my residents when we talk about like electrical energy and things like that, and like, you think you sort of like checkbox physics is like when you're in undergrad, and it becomes actually part of like every day in the operating room. Coding, I'm not as sold on, right? Because the value, I think, of a clinician is not so much in being able to write the code, and honestly, most of my engineering students aren't even writing code anymore these days, right? I think the reality, though, is, you're right, though, this idea of the translator, right? Who is the translator, the interpreter between the two? So very much, I think this co-education becomes incredibly important between engineers who need to understand what it is that we do in medicine and our trainees who need to understand at least the basic engineering principles. Rachel Acker, maybe here, she comes to these lab meetings with engineers, and we have lots of discussions around, well, what do you mean? Like the pancreas is yellowish in color. What kind of yellow? Why do you think it's yellow? Some of these questions we get from engineers we take for granted, right? That like we really be explicit about. But I do think that some of these fundamental things do need to be maintained in probably pre-medical education. And then I can tell you at Penn, we've incorporated into the undergraduate medical curriculum throughout. We've woven it into all of their existing sort of preclinical classes, elements around AI and probability, not so much linear algebra, although that's a huge piece of AI, obviously, but the conceptual understanding of what it means so that there's some fluency that's developed. In Canada, there's a recommendation to make digital health literacy one of the fundamental competencies by the Royal College of Physicians and Surgeons. And so there's certainly a movement toward that, and it's trying to better understand how do we fit it in. And then the big question, and this came up in the Blue Ribbon Committee too with the American Surgical and the ACS, well, if you add one thing, what are you taking out, right? And so really figuring out that balance of how we balance medical education.
Thanks for that. The other question that I had with regards to what you were bringing up, that AI can reach the conclusion, it doesn't matter how it reaches the conclusion as long as we can get similar outcomes. And I think that goes down to logical consistency. I agree with that. You can prove the Pythagorean theorem like dozens of ways, but they're all logically congruent. I think if AI can tell me that 1 + 1 = 2 because a hamburger has 2 buns is not the same thing as Lord Russell's 400-page proof. And the question is, how can you actually measure logical consistency in order to prove that everything that we're saying is ultimately congruent?
Yeah, that's a great philosophy question that I don't think I'm quite equipped to answer. But it's point taken. I think the question then is, how much of our decision making do we require to be logically congruent? How many times do we change our practice because of a randomized control trial? And then all of a sudden, we know logically, right, that actually is not applicable to everybody, and yet we then incorporate it into our guidelines and treat it like this is like infallible fact. So what is our expectation around these models when we don't hold ourselves to the similar standard? And then that's, again, sort of coming down fundamentally to how humans perceive machines and what we expect out of them, right?
I have one last one. Sorry.
No,
No?
not allowed. Sorry, gotta have to stop you there. Let's do one more question for Dan, and then the good news is we have a 1-hour break before the next session in this room, so I think whoever wants to stay and ask more questions, Dan is here. And then the good news is Dan is on a panel again this afternoon. So there's going to be a lot of opportunities. So go ahead and ask your question. Shorter question would be great.
Yes, Ted Michalakos from Chicago. I'll just skip to my second question immediately. That was an unbelievable talk. Thank you very much. The real question is, for early career surgeons, what is the recommendation you would give in order for us to be able to coexist with this technology in the future? Because it seems inevitable that this will make it to clinical practice at some point. So other than understanding, make sure we understand the shortcomings and abilities of those systems, what are some other recommendations that you would give to someone starting on now in order to be able to survive in this environment?
Yeah, I think the key thing that I tell people is you already have all the tools that you need to really interact with these things, at least conceptually, because just like we evaluate the evidence before we're going to prescribe a new medication or before we decide to adopt a new technique in the operating room, we need to be approaching these technologies in the same way, right? We need to be thinking about these in a methodologically rigorous way, as opposed to just thinking, oh, this is cool, like, and this is available now in my health system, I'm going to use it, right? We have to personally take responsibility for how we decide to use these things. And we have to do that in a way that is, to the other question, logically congruent with how we're treating other things that we incorporate into our practice. And I think that's the most important step that I think I want to highlight to people, is that in the same way that you evaluate a paper to understand whether you want it to impact your practice, you should be doing the same thing with these technologies.
Okay. Dan?
All right, thank you.
We have a small gift for you. Thank you very much.
Thank you.
For your time.
Thank you so much.
For your
Appreciate it.
commitment.
Thank you.
We'll get you together.